Now it's me. Good afternoon. I'm very honored to be invited here, and I was also very impressed by this morning's presentation. It's a daunting future we all have ahead of us. It's daunting in a sense that we actually have these numbers that tell us that healthcare is the most complex industry that mankind ever has tried to master. It's so complex because it's so many steps, so many people, so many professions, so big part of the society that we really need to think about healthcare not as a complicated system, but as a complex system. A complex system cannot be ordered around. A complex system can only be offered different incentives in order to do the right thing. The most important driver in healthcare is the passion of people in healthcare. They are there because they want to do good for their fellow human beings. And by actually trying to put numbers on the way you actually do good in healthcare, you can actually drive healthcare quality. It's been shown in many cases, and it has been shown under different theoretical umbrellas, as we heard today. But today's theoretical umbrella is value-based healthcare. And value-based healthcare is an interesting issue because it, for the first time, puts everything together: economy, patient quality, technical costs, evidence base, etc. All of it has to go in and provide the right landscape in order to provide the right incentives. My name is Martin Ingvar, and I am an academician by training and have also a clinical training. And I have been interested in patient behavior and healthcare behavior for a number of years. And I had the opportunity to be part of the inception of ICHOM, International Consortium for Health Outcome Measurements, which is a not-for-profit organization. That means that it's an open, academic principle-driven organization where we try to develop standard measures that can be used by everybody at no cost, with the idea that if everybody used the same measures and published them, we can actually start to understand what type of quality we deliver in healthcare. Let's see. The problem that we have in healthcare, the old service model, is that we do a lot of things that we don't need to do. As Jens Derberg showed, we have a high variability. Sorry, guys. A high variability. And we focus on the local service, that is the intervention, rather than the long-term outcome. And above all, we don't really know what happens to the patients. This means, sir, please, I can't hear myself thinking, I'm sorry. We focus on the wrong things. The theory basis for value-based healthcare means that we have to work together. It means that we have to deal with the idea of actually asking the patient what they want to, where they want to be in a few years. We have to ask the patient about their health. We have to measure the outcomes, and we have to improve our information systems. We had a wonderful lecture this morning about improvement of the information basis for healthcare, but I tell you, we haven't started yet. There is no ideal place in the world yet, and the development is going very fast. And I have a slight difficulty here. And then we have to deal with one more thing, and that is that healthcare today is a very difficult and complicated trajectory. It's a whole path that the patient has to take. A patient with, for instance, a chest pain that enters a hospital will meet some 100 people before they're out of the hospital. How do you know which one that contribute with quality for that patient? This means that we have to be far better at catching the information along the patient route. So what does ICHOM do? ICHOM puts together academic groups across the world that determine which are the best outcome measures, and they invite patient and patient representatives to participate in that. So far, ICHOM has put together standard sets for some 30 diagnoses, which covers about 50% of the disease burden. That's a good start. The work is continuing. Any healthcare organization can bring these standard sets from the net to their own organization and start using them for free. It's there. The only thing is that there is an implicit contract. If you use them, please publish your results. And because the aim is to get transparency in the quality measures, and by measuring the outcome and not the process. People can perform their healthcare any way they like, but they will, in the end, only measure the outcome. Which means that if somebody finds a cheaper way, a better way, a way that's more liked by the patients, that is the one that probably should prevail. So we're trying to move focus from process measurement towards outcome measurement. And we also would like to see that the accountability for what you do in healthcare move away from measuring the individual healthcare worker to the system as a whole in its ability to drive quality. However, let me see, this means that we have to teach our information systems not to be limited by the walls of the hospital. We have to follow the patient along the full healthcare trajectory. This also means that we need to increase the focus on the primary care, that in order to decrease the flow of patients to secondary care and increase the quality in the reception of patients coming from healthcare. We need to unify our information systems. I'm not a believer in one system. It's not going to happen. One system means a big investment that will be outdated by the time it's installed. We need to have a system with a unified language, but probably many systems. The word for that is called semantic interoperability, meaning that the language between the systems is the same. That means that we can actually harvest data without moving the data. Harvest the data means that we can calculate the local quality and compare it overall without moving the data around. Patient must always be in the center. Working around the patient trajectory means that we can provide an electronic medical record that should be structured in a way that we can get research data. We heard this morning about real-world data. Real-world data means that we can actually get data from practical healthcare. As I said, we follow the trajectory. We have a process design saying that this is the ideal way we should do with these types of patients. Of course, it must be individualized, but at least there is a basic process that supports a proper evidence-based way of doing it, and also remove a lot of the waste that otherwise is done. And the work tools should support all the professional groups in healthcare on an equal basis. Today's medical records, most of them just talk to the doctor. And I tell you, there's a lot of money to save by seeing that all professional groups get good information. When you create a process, involve all the groups, the professionals, the patients, the providers, and academia, and get yourself a unified picture of where you want to go. That's actually the real issue here. You can't tell a complex system what to do. You can only ask it, where do you want to go? See that they get the right incentive, and you will see miracle happens. We tried this we have a catch area around Stockholm of about 2 million people. And we had a very difficult situation with poor handling of cardiac congestion. And we built a process around this with patients and and also a process around a chain between secondary care and primary care. And in 2 years, we were able to increase patient satisfaction, improve outcomes, increase professional satisfaction, decrease the number of hospital nights with 14%, and also we were able to decrease the cost, paying for the project about 28 times when we did it. Just demonstrating that if you involve the people that are actually doing the process when forming the process, you have a major tool going ahead. So co-creation is what we call that. And then planning the process along the trajectory, as I said, you have to have some sort of computer assistance so that you know where in the process the patient is. Otherwise, you won't gain so much from the process work. There are a number of systems doing it today, but when you start going for electronic medical records, be sure that your procurement is adamant about the fact that you need a process support doing so. And that process support actually means that you can automatize getting the data while the patient is traveling along the process. This means that we can actually monitor the process while it's going on, and then later understand what happened during the process that's actually contributing to the final quality. This way, the quality improvement system is actually embedded into the information system as such. And number 5 of my points is that today's patient, it's not enough to go from disease to health. We also need to promote wellness, and by integrating those two, we are able to delay the what we call the NCD train, the non-communicable disorder train, that is now hitting healthcare. Remember that in the affluent societies, and also including Russia, more than 45 to 50% of what we do in healthcare is avoidable, provided that lifestyle is improved in the general population. I'm not just talking about alcohol and tobacco. I'm also talking about overfeeding, ill-feeding, and sedentary lifestyle. 50% of what we do, that's the real money that we can find in that one. And how do we provide the system with the correct drivers? It turns out that information, the feedback information, being really sure that we get the feedback very quickly back to healthcare is really the most important driver. Jens mentioned the case when the cardiac registry in Sweden opened up some years ago, where we had a very big difference between the best and the worst hospitals. With the beginning of transparency, we were able to push the quality in the lower section of those. And today, it's possible to say that none of the hospitals in Sweden deviate from the European guidelines. There are a number of other examples, and I have more recent ones as well. And some of them are really sad, but I will not take them now. So, the ICHOM initiative has engaged some 500 academicians around the world in putting these data together. And we invite also Russian academicians, if you would like to participate in the continuous work. And the important thing is that these outcome measures, they are freely available. You can use them as much as you like. The organization is patient-centric. Not right now, but it's coming there. And that means that we have, in the outcome sets, you have measures that are there for case correction, measures that reflect general health, and measures that generate the subjective health measures. And then, of course, there are diagnose-specific measures. This is important because we have to remember that in many of the cases of chronic disorders, people have more than one disorder. And you don't want to measure the same thing for one diagnosis and the same thing again for another diagnosis. Of course, you want to do the general measures once and the diagnose-specific when applicable. This way, you can maintain the individual, the individualized medicine in spite of the fact that you use standard measures. So, with this I would like to finish and say that the idea of ICHOM is that healthcare should compete not on the fact that we have more specialists, or we have more technical ability, or we have shorter waiting lists, or we have a very good hospital logo. Healthcare should compete with real quality numbers. That's the only way where we can provide the correct value from healthcare industry to society and to the general population. And it's my hope that ICHOM can be a contributor to that. Thank you.